Okay, I think we'll get started. Welcome, everyone. Happy end of February. Thanks so much for joining us. Today, we're really excited to host a PCRC webinar with Dr. Stephen Bartels on implementation science. We're back in our regular webinar format today, which means attendees are not able to unmute themselves or turn video on. However, we wish for you to engage with us by entering your thoughts in the chat and your questions in the Q&A feature, which is a button in your Zoom toolbar. We'll address questions at the end of today's presentation. That's about the last 20 minutes. And today we also have Dr. Christine Ritchie, co-chair of the PCRC. And so I'd like to turn it over to Dr. Ritchie, and please introduce our speaker.
Greetings, everyone. It's really great to have you here, and we're so glad to have with us Dr. Steve Bartels, who is the inaugural James and Jean Mongan Chair in Health Policy and Community Health and Director of the Mongan Institute at Massachusetts General Hospital. Dr. Bartels is a professor of medicine and leads this institute, which includes 12 centers, including the Center for Aging and Serious Illness, along with 140 faculty who are members of the center. He's also an amazing teacher, mentor, and investigator. And actually, I don't know of a better person to give a talk on implementation science than Dr. Bartels. So you are in for a real treat, and I'll hand it over to Steve.
Great. Thanks so much, Christine. Really pleased to be here. So today I'm going to do an overview of implementation science with an emphasis on older adults. And for those of you who are experts already, apologies. This will be a bit introductory, but I was asked to provide really an overview of the field. And also I'm going to focus especially on the whole area of adaptation as it pertains to older adults with a specific area of focus. So what I'd like to do is start with kind of what are we going to talk about, and what we're going to talk about is, first of all, why is implementation science important? Why should you be thinking about this if you're not, knowing about it if you don't? What is implementation science? How do we do it? How does it sit in the translational continuum? What are frameworks, outcomes, components? How do we think about fidelity and adaptation? Then I'll finish with some resources for you after we have time for Q&A and discussion that hopefully will be helpful to you, some things we put together here at the Mongan Institute as a resource guide. So with that as a kickoff, why is it important? You probably know about this, but if you, it's always bears reminding, and it's always helpful for me to think about this issue of the fact that, from time of inception of idea to actual implementation and real care, it's been suggested and looked at that it takes about 17 years to transform only 14% of original research into the benefit of patient care. Every time I think about this, it's astonishing to think about NIH and foundations and the fact that we're taxpayers, but also wanting to make the world a better place. And it takes much too long to get only a minority of research into practice. Well, I was kind of skeptical about this when I first heard it, frankly. I thought, I don't know. This sounds like, certainly in cancer care, this is not true, that many discoveries are moved quickly into practice. And certainly with COVID, with the recent COVID vaccine development, this was not true. This is more about kind of general non-urgent and perhaps non-cancer related chemotherapeutic interventions. So those aside, is this true? Well, I looked at my own research. I thought about a project that I got involved in many years ago, where we started to look at health promotion and coaching for people with cardiovascular, cardiometabolic disorders who had major mental health conditions. And I identified a really cool program in New Hampshire that already existed, and a colleague of mine. And we thought about doing a pilot study, which I did. I got some funding from RWJ on that, on top of that, to do a larger pilot study. Then decided with promising results to do a randomized trial, which we did, and then did a randomized replication trial. and then decided, after finding out that both studies showed that we could, in over half of the individuals, including ethnically diverse individuals, reduce cardiovascular risk and predicted mortality, that we might implement it. So we did a kind of statewide pilot implementation study, and then we did a national implementation study, looking at 2 different implementation strategies over 50 different organizations across the United States. It didn't take 17 years. It took 16 years. So there you go. It's probably close. But even if you wonder about that, and let's say, think hypothetically, and this is something that Russ Glasgow slide from his thoughts about this, which I thought was really compelling. Consider like hypothetical cancer treatment that is 100% effective. Couldn't be better. Well, it's only as effective as how well it is, A, once it's discovered, adopted, B, practitioners are trained actually to deliver it in the way it's supposed to be delivered, C, trained practitioners choose to deliver it among all the things they might do. Then next, eligible populations receive it. And then once it's actually put in place, it's sustained. It doesn't disappear after it's introduced. Well, if you do really well at each one of those steps, and we might agree, a 50% rate is pretty good in real healthcare systems and healthcare delivery. Well, 50% at each step, only 3% end up benefiting. So that kind of hypothetical math operation does hopefully really impart upon you how it really is the case that these are important issues in terms of implementation, not just discovery. And then we also know that if you think about any outcome, actually, the extent to which we do good implementation of an evidence-based practice really has downstream implications for pretty much everything, and that includes initially uptake, whether or not there is initial uptake. And then whether or not once it's taken up, it's sustained. But then also things like cost, safety, quality of care, quality of life, mortality and morbidity. All of these things are impacted for delivering interventions and models of care in the context of how well something is implemented. So it really is pretty much everything that gets affected by execution downstream after discovery occurs or something shown to be beneficial or an evidence-based practice. So therein lies the rationale for implementation science. So what is implementation science? So the initial definition that has been promulgated and kind of stands up to the test of time is that implementation science is this study of methods to promote systematic uptake of research findings and other evidence-based practice, either findings or things that are clearly evidence-based, into routine practice. And in doing so, to improve the quality and effectiveness of health services. So that's the fundamental kind of base definition. So digging a little deeper, implementation research does a number of different things at its inception and has changed over time. But when we started in this adventure about 15 years ago, when the dissemination implementation research field started kind of germinating and developing, many of these things still hold true today, that certainly identifying barriers and facilitators to putting into place evidence-based practice, developing and testing and identifying strategies to increase the use of those practices, to facilitate not just implementation, but adoption, widespread adoption, and so-called spread or scalability of these practices, to understand better the processes behind what works and what doesn't, and where the levers are, what are the mechanisms, what are the components or so-called facilitators, internal, external facilitators, different mechanisms, processes, and then to iteratively develop and test theories, hypotheses, methods, and measures to actually engage in science and research in a real field that develops a robust area of theory, practice, frameworks, outcomes, and ultimately findings that are empirically derived. And then ultimately to support real improvement in organizations and at the level of individuals. So where does this fit in kind of the so-called translational spectrum or in the area of intervention research? Well, if you look at this table, what you'll see is that on the left-hand side is what all of us who've been in the field of intervention research have traditionally called efficacy trials on the left-hand side. And those are those tests of A versus B, some sort of, whether it's a medication or an intervention, a psychotherapy, a psychosocial intervention, a case care management intervention, in the most optimal circumstances possible. We just want to know, does it work compared to a control condition? And this is fundamentally done within a relatively tightly controlled research environment or well-constrained setting. Lots of exclusionary criteria. You want to get any noise off the table so you can see, does, for example, this medication really work when you don't have all sorts of comorbidities, when someone actually, someone takes it because you watch them take it as administered by somebody who's an expert, and that the intervention is delivered by a highly trained staff with high involvement of the research team. And the whole focus here is internal validity. Does it work or not under the most constrained and clean circumstances? Well, after that, many of us who didn't do that sort of work, including myself, we were more interested in effectiveness trials. It's like, okay, that's fine, but what about the whole population? What about real people in real settings? How do we know that A versus B works, whether it's cognitive behavioral therapy or care management or palliative care, measures and models of care in the community? How will that work in real settings, in real world settings, delivered to real people with few exclusions? We're going to make sure that multimorbidity or multiple conditions are present, that these are real individuals, some who may have other sorts of complications of all ages or in a very targeted, significantly challenging group of individuals, and that we look at real health outcomes, and that the delivery of that intervention is usually by practitioners, not researchers, some involvement by the research staff. And we're interested in both, does it work and does it work in real settings? So we're interested in kind of a balance between internal and external validity. Then there's implementation trials, the next step, which is what we're talking about today, where really the question is not so much usually does the thing work, but the thing that we know works, how do we get it adopted and sustained in the real world by real providers with very few exclusions in messy healthcare systems or clinics treating diverse populations? And the outcomes there are not so much person-level health outcomes. Does it work? Does hypertension go down? Does diabetes get controlled? Is depression resolved? Are hospitalizations decreased? But did it get adopted? Did it get adopted with so-called fidelity, the way that it was designed? Was there sustainment and spread? Did it get into place and used? And there, the unit of analysis is often practitioners or organizations. We're interested, but we're not necessarily measuring primarily patient-level outcomes. We're really looking at the unit of analysis, practitioners, organizations, clinics, limited involvement by the research, and the whole focus, or much of the focus, is external validity. And then finally, and we'll get to this in a couple of minutes, there are hybrid effectiveness implementation trials you may know about, which are really a synthesis of both effectiveness and implementation trials, in which we're interested in simultaneously and rapidly figuring out, is the treatment, is the implementation effective, is the intervention effective, will it be sustained, adopted? We're interested in both health outcomes at the individual level and at the organizational level, and there's internal, external validity are equally measured. So this is kind of the way to think about these domains and kind of the march of science. But to get a little more specific about what we mean when we test implementation interventions or strategies, which is what we look at, we often test how can we get something into practice that we know works, Well, is it through electronic health record reminders, templates, prompts, nudges? Is it through technology-assisted interventions? Certainly with COVID, we've learned a lot about that in terms of whether or not we can deliver things either remotely or through apps or through embedded technology within home settings, et cetera. What about the old standby, education and training? Does that work? Can we train physicians, train nurses, train clinicians? Necessary, but not usually sufficient, and certainly not innovative in terms of implementation. Audit and feedback also been around a long time, giving people their results around how they're doing, and dashboards, comparing them to how, whether they're a clinic or a practitioner, doing relative to their peers, having some way of kind of revealing to individuals where they stand on with respect to other metrics. Certainly, behavioral economics and incentives is one strategy that's been used, and obviously is used a lot in healthcare systems around incentives or so-called rewards. Toolkits, pretty popular. Those things sometimes can be helpful, but then it becomes sometimes challenging to know what happens with a toolkit if somebody keeps on reaching for a so-called hammer as opposed to all the tools in the toolkit in terms of an implementation around a healthcare intervention. Technical assistants, community health workers, on and on. There are many strategies that one could think about for implementation to test. These are just a few, but suffice it to say, we're really interested in figuring out how do you get into place things that we know work. Well, once you sort out which strategy you want to test and what's going to have the most potential theoretical bang for buck, how would you measure whether or not it has an implementation outcome that you care about? Well, one of the most common standard outcome measures that is worth knowing about for sure, and is one of the kind of guideposts for all of us, is Glasgow's RE-AIM about reach, adoption, implementing with fidelity, and having long-lasting effects. And so if you look at this kind of as a conceptual framework around outcomes, effectiveness is only one of the outcomes. Reach, really important if you think about equity, right? You could have something that is a very effective intervention, and you've come up with a way to deliver it, and you deliver it really, really well to 10% of the population. Good effectiveness, bad reach. And what if that 10% of the population is the most affluent and able or capable or mobile? You really have failed in essence, particularly if you're interested in frail older adults and palliative care or other individuals that are compromised. So one of the real, I think, key issues to ask in any implementation strategy is, does it get to the people that it really is intended to get to, and to the organizations that it needs to get to? And again, it's often easier to put into place effective interventions in research-ready organizations or clinics and get them to people that are mobile, health literate, and seeking care. The real challenge, of course, is having evidence-based practices reach people who are experiencing health inequities and health disparities. So that's really important. And certainly adoption, getting uptake, not so easy in healthcare systems. If you're really interested in healthcare delivery science, like I am and many of our colleagues are at Namongan Institute, it's how do you get an organization to adopt and take up something? I have a colleague who's at our institute who's been developing decision aids for years, Karen Sapucha, and putting them into place. Well, how do you get an organization to do the right thing, which is to provide decision aids for shared decision making when they're busy doing other things? What are the ways to get them to adopt it and to put them in place, and also for really challenging populations and decisions? And once you get it adopted, people say, yes, we're going to put it in place. Did they put it in place and adopt it with relatively good fidelity? By that, I mean, did they follow the use case, or did they put it in place in a way that's likely to make it work and be effective? Is it pretty close to the evidence-based practice that was tested and published in a randomized trial? Or have they wandered significantly in a different direction in terms of the way that it is actually implemented and the way it's being used? And does that, in essence, result in it not being as effective? And we'll talk more about this in a few minutes. Or is the wandering to changing it a bit actually a positive? Did they do some sort of adaptation that actually makes it better? And then once it's in place, does it sustain? I'm sure you all have experiences with things or grants or know of projects, which when the grant was in effect and funded, that everything was going well. And then when the grant went away, the intervention went away. And so this issue of sustainment now has great interest in the field of implementation science. So I would say among the hottest areas recently in implementation science really are in these areas of equity, focused implementation science, we'll say more about that in a bit, and sustainment, maintenance over time, and adaptation. Those three areas we'll say. And then finally, effectiveness. Does it work? Once you put it in place, but really kind of in that order, which is a little counterintuitive for those of us who are trialists, who think about effectiveness being the primary thing we look for. We already know it works. The question is, as a confirmatory issue, we want to see if it works. But overall, how do we get it in place? Now, one way of measuring outcomes is through this idea of CFR, of RE-AIM. Another is to think about the process of implementation. How is it implemented? And so a common framework that's been used by many of us for quite a while in terms of the process of implementation, not the numerical outcomes, reach, effectiveness, things you can, but often the issues of the process. How did it get put in place? What were the things, the variables, the facilitators and barriers to implementation, things that actually changed or altered the way in which the success of the implementation happened or not? That might be the characteristics of the intervention. Is it complex or is it simple? Does it have triability? Was it designed properly? And more recently, there's great interest in user-centered design, so-called design thinking, participatory co-design, with the idea that maybe the problem with implementation was really not in the receiving end structures, the so-called barriers and facilitators of the organizations, but maybe it was never designed for broad reach, broad implementation, that the academics who put it together designed it to work, but only in rarefied settings where you've got lots of resources and skilled professionals. It never, ever, if anyone was at the table when it was designed to actually worked in a federally qualified health system or in a home-based care system, they would say, this is a nice try, probably will work, but we can never deliver it in this setting. Well, that's the issue of the intervention characteristics. Then the inner settings. What about the culture of the organization, the structural characteristics, the readiness for implementation, or the outer setting like policy, financing? You can develop a really cool intervention, but if Medicare won't pay for it, that's a problem. Or if you're working within a cost-based fee-for-service system that changes over to an accountable care organization, bundled care, those things can change dramatically how things work. And then the individuals. Who are these people that you're targeting? Both the providers, the so-called patients, the attributes of those, the characteristics, then finally the process. To what extent was planning, engaging, executing, in a really planful way? So this is another way of characterizing the implementation, more as a descriptive and often using mixed methods as opposed to strictly quantitative measures. Now, we use in implementation science all sorts of designs. We use randomized controlled, sometimes stepped wedge, adaptive randomization, quasi-experimental. Sometimes randomization doesn't work, but it's suffice to say that in our field, simple randomized trials, we've done a number of them where it simply was strategy A versus strategy B. If you want to put in place, as we did for this large national study, a health promotion intervention to reduce cardiovascular risk? Do you do it through bringing together organizations in a so-called learning collaborative, or do you do it by technical assistance, one agency at a time? Or alternatively, do you do electronic health record reminders versus some sort of health coach intervention? I mean, how do you put in place things? And one versus the other, we don't know. And again, it is the case, though, that we can sometimes both test the effectiveness of something and its implementation. So Curran put together a number of years ago this idea of hybrid implementation effectiveness trials. On the left-hand side is fundamentally an effectiveness trial, where we ask, is A better than B in terms of an intervention? Let's say a intervention for managing diabetes, A versus B. Does it work? And then we're also going to observe barriers and facilitators and document them. But we don't know whether this intervention really works. So it's fundamentally a primary effectiveness trial, secondarily an implementation evaluation, which we do passively. On the right-hand side, hybrid type 3, we know this thing works, whatever it is. We know that care management or whatever for hypertension or diabetes or health promotion interventions, we know they work. That's not the issue. The issue is we can't figure out how to get it implemented in broad settings. So it's all about the implementation strategy, A versus B approach to putting it in place. And we're going to secondarily document that it works because we kind of care. We kind of know it does if it's implemented properly. Type 2 is really interesting, where we simultaneously test both the effectiveness of something and the implementation strategies at the same time. We're seeing more of these recently. They are a little bit complicated to be simultaneously testing both how you implemented something and the effectiveness of the thing that you're implementing. Clearly, both have to have enough pilot data to support their potential promise. But these are ways of really accelerating science. If you think about this painfully long process I described earlier, first starting out with an efficacy trial, going to an effectiveness trial, and then piloting a small implementation, and then doing an implementation that take this whole 17-year history. Well, what if you were able to test effectiveness and implementation simultaneously? We can start to really change the world more rapidly. Now, it is the case that A versus B studies are great. They're kind of what we've been learned in graduate school or in fundamentals of clinical research, but it's not the way real practice works, right? You don't kind of give somebody either drug A or drug B and then sick that for 3 years to see whether they get better, like in a grant. You actually, if it doesn't work, you change things. And so increasingly, there's been interest in adaptive designs, smart trials, and others, in which you might, in fact, first randomize somebody to, in this instance, an implementation strategy, not just a treatment. And then if it works, stick with it. If it doesn't, randomize again and add something. And so these adaptive designs are really interesting because they increasingly mirror what happens in real world around adding things, augmenting, changing the context or changing the way in which you're fundamentally doing the implementation if the implementation doesn't take or if the intervention doesn't really work. So those are among the designs issues. But when we put into place something, we also want to know, again, did you put in place the thing that was tested and shown to be effective? Is there fundamentally fidelity? So this is the degree to which an intervention or program is delivered as intended by the program developers. Now this, for years, we would say you better have a fidelity measure when you do an intervention study. And if there's fidelity drift, that's a bad thing. That if people don't do it exactly the way it was proven to be effective in a randomized trial, then the guarantee is off, and that's not a good outcome. Maybe. Is it always the case we should continue to do the same thing the same way once we put it in place? Well, Darwin didn't think so. If you think about sustainment, if you think about an intervention that's put in place or a thing, if you don't evolve over time, if it doesn't adapt, maybe it doesn't do so well. And so increasingly, this idea that to sustain an intervention over time, it needs to actually possibly evolve or adapt. It can't be exactly the same thing as when it came out. And certainly we've learned that with COVID, where everything that was so many things that were being delivered or implemented face-to-face had to pivot and be delivered electronically or through other sorts of hybrid mechanisms. And so that adaptation had to happen, or the whole healthcare system would have gone down in terms of preventive care and many sorts of things that we did. So adaptations have increasingly become really important, and adaptations are changes to the design or delivery of the evidence-based practice with the goal of improving fit in a particular setting or population, effectiveness, maybe even making it more effective, or sustaining it, all the above. So what does that mean? What does it mean particularly for older adults, for example, with special needs and challenges? Well, clearly, we know very well that things that were developed for young adults, interventions, medications, et cetera, but particularly interventions, can't just be directly delivered to older adults with the expectation that they'll work exactly the same way without adapting them. That the issues around co-occurring chronic health conditions, polypharmacy, cognitive impairment, loss, bereavement, physical functions, sensory limitations, issues with respect to comorbidity, transportation, access, on and on and on. So, we know this, but clearly, if we're going to put in place things that work in younger populations, there needs to be adaptations. And one might argue that particularly frail older adults are, in fact, just one form of a health disparity population, along with other areas, race, ethnicity, disability, LGBTQ status, a number of these things that actually converge on this idea of adaptation for fit, particularly, for example, with respect to, cultural adaptations or so-called equity-focused implementation. So certainly we want to think about adapting evidence-based practices and doing so in a systematic way to engage and to be effective with respect to health disparities, health inequities, the growing diversity of the older population, which is rapidly happening across the United States and the world, lack of cultural and social factors that are fundamentally initially incorporated into EBIs that weren't really there. Really thinking at the front end about these issue of racial and ethnic minority participants. So what does it mean to design for health equity in terms of implementation? A colleague of mine, Leo Cabasa, who's written about this with Anna Bauman, and there have been many papers since, really set a very set of usable and fundamental principles around designing for health equity in terms of thinking about implementation. And as I said earlier, start with reach from the beginning. We can all develop things that can be effective if you throw enough resources at something. But what if it's too expensive or too focused on an institutional setting or too difficult to access or isn't really designed to reach the population of interest? You might imagine an intervention which works really well for clinic populations, but wouldn't work at all in a homeless population that has no place to live, can't do home testing for diabetes or dialysis or something like, this becomes, we have to think right out of the gate in terms of how to reach that population, if that's the way you want to advance equity. Designing and selecting interventions specifically for vulnerable populations and low resource communities with implementation in mind. Implementing what works and developing strategies that are specifically targeted to decrease inequities. Developing the whole science of adaptations and then using an equity lens for outcomes. Again, modifying the way we think about outcomes. And so this idea of equity-focused adaptations has been increasingly so important that these are both planned adaptations and ones that also occur spontaneously and that we measure over time. And the question with adaptations often is, what can and cannot be modified? What's immutable? What is core? Obviously, if you completely transform and change the effective intervention to something that doesn't even resemble it, that's not an adaptation. That is perhaps something that's going to break the intervention, make it not work. But how do you know what's core? What's the difference between adapting and changing it? What are the core elements? What can be changed without interrupting its effectiveness? Well, certainly there's ways of characterizing adaptations as a process, and Wiltse Sturman has championed this area. This is the original framework. There's a more complicated framework that follows this that I'm not presenting, but fundamentally, it really asked fundamental questions about why was it adapted or how was it adapted to characterize the adaptation process. By whom was it made? Who made the adaptation? Was it the researcher? Was it the population? What is it? The content, the training, the context? How was it adapted? At what level? Hospital, community? And what's the nature of the content modification? Is it tailoring or tweaking, changing a little bit, adding, augmenting, reordering things, or completely dramatically changing it? So the basics of adaptation really are the why, the what, the where, and the who in terms of adaptation. And again, this becomes particularly important in vulnerable populations and in terms of this. And again, when we think particularly about the why, often it's about improving fit, increasing reach or engagement, increasing retention, improving feasibility, addressing cultural factors, many of these things, sometimes reducing costs and increasing reach and satisfaction, but knowing why something's being adapted, really important. And then even more important, what are core? What's core? And so Brian Mittman's talked about form versus function, this idea that you can change the form, but if you change the fundamental function of the thing, you have trod on ground that's likely to make the implementation fail because you've altered the guts, the true essence of what makes the intervention effective. And so in that vein, David Chambers, who's really been a leader in the field around both adaptation, but also for many of us thinking about adaptation, asked this question, but what makes, in terms of adaptation, what makes a turkey sandwich? What is it? Well, both of these are turkey sandwiches. One of them has cheese and has lettuce on top of it. One of it has sprouts and other sorts of things. But we can all agree that these are turkey sandwiches. That's not a turkey sandwich. That's a slice of turkey, a pile of turkey. So you need bread and you need turkey. Everything else is garnish. Well, what is the core component of an intervention for which everything else is garnish, is added to the core elements? So by way of overview, the key characteristics, what is implementation science and how do we think about it? The major characteristics of implementation science are the fact that, first of all, we take a systems perspective, that we are fundamentally health system scientists in many ways, that we embrace complexity. We like complexity. We don't run away from it. And that's multi-level complexity. Complex patients, complex systems is where we live. Context is critical. When you go to meetings on implementation science, everyone's talking about context. And that's because we've learned the hard way, perhaps, that what happens outside of the implementation process can make all the difference. And again, in looking at a implementation in assisted living settings across an entire state for preventing COVID in a study that I'm writing up this very minute, everything changed. The context changed from month to month. The base rate of COVID changed. The recommendations around how to prevent COVID changed. We started out, there weren't even vaccinations, and we were washing fruit and we were masking everybody and doing contact tracing. And what worked. And then the base rates changed, went up and went down. The policies around sequestering individuals or letting individuals be able to be mobile, the policies around the workforce in assisted living and nursing homes, et cetera, really changed over time around monitoring infection, mandating vaccines, vaccination rates changed. Just think about it. The context of implementing a prevention strategy, just everything, literally we counted about 19 contextual changes. It almost begs, how do you do research when, in complex changing it? But increasingly, as we know, the world is rapidly, dynamically changing. And I think we need to embrace ways of measuring and adopting and testing these change items as contextual factors that influence real world implementation. Simple A versus B doesn't really apply in real systems with real patients. We also are very interested in practical, pragmatic, not highly burdensome measures, and scalability and sustainment is really important. If you want to change the world and have a public health impact, really needs to be both scalable, used by lots of people, and sustainable. It'll survive time. And then, as I hope I've tried to impart upon you, not only do we want to do rigorous science, we want to do accelerated science, rapid science increasingly, but that it needs to be adaptive. That often we need to think about the ways that adaptation in methods and approach in the context of things occurring outside, but adaptation in the way to improve fit, improve effectiveness, improve sustainment is really critical and particularly important in vulnerable populations specifically. And in that we also, over time, I think, need to think about the fact that there's multiple ways, multi-level modeling, multiple approaches to understanding and conducting these sorts of studies, and infinite amounts of ways to consider how to effectively put in place these interventions and study them. And that we really have to have, I think, respect for diverse approaches and some humility in this, but also increasingly, I think, doing the hard science. The field of implementation science has been appropriately criticized for having too many frameworks, too many theories, and not doing enough tests. And so increasingly, I think the study sections and grants are being really pushed to actually answer hypothesized questions for sure, and not simply develop frameworks and theories, but test those frameworks and theories. So finally, if you have if you're interested around any of these issues, around introductory issues or strategies, frameworks, specific questions, or things that have to do with special topics, whether there be sustainment or health equity or other areas, we've put together a web page that you can see here that's called the Implementation Science Resource Navigator. It's free and provides for you a kind of a curated entry point to among the best websites that we could find, organized in a way that will help you to navigate either introductory questions and videos and some materials, or very specific questions around which framework to use and how you might adapt those and use them within your own research. So with that, I'm going to stop my presentation and open it up for questions and comments.
Thanks, Steve. There's always good learning to be had when I get to hear about implementation science from you, and I'm hoping that we can get some questions and answers from our participants. I think a question that we often hear, and which I will ask you, is I have a plethora of questions, but I'll start with one, which is how do you decide what implementation framework to use?
Well, I think I think increasingly study sections are becoming more critical about actually using the appropriate framework. So I think one of the defaults in terms of quantitative outcomes, as I mentioned, REAIM is pretty safe one, and a lot of people use it, and it makes sense. But if you're really trying to understand the process of, what's getting in the way of implementing, not really the reach or the effectiveness. Then we tend to revert to see further consolidated framework for implementation research. Those are kind of two of the kind of basic. But after that, there are literally we've counted to 75, 80 frameworks that the field has promulgated. And I think they're asking the question, are you really focused around looking at equity? Are you really focused on something that has to do with cost effectiveness? Are you really focused around participatory design and iterative design and user-centered? With those more sophisticated questions, there are frameworks that start to be much more appropriate. Or are you trying to do, again, some sort of hybrid effectiveness or implementation? And then there's frameworks that kind of mirror those. And so I think becoming a student of some of those, but also looking at asking people that are willing to do consults around some of these things, I think is one way to think about it.
Great. And since I asked that question, a whole array of questions have come in. So the first one is, how would you distinguish implementation science from a quality improvement project?
That's a really great question. So I once literally had a debate with a good friend of mine, Gene Nelson at Dartmouth, where we kind of said, I proposed the thesis that quality improvement is a subset of implementation science. He argued the opposite, and we had a great debate. I think it's safe to say the following, though, in terms of quality improvement. There's quality improvement as an operational function within any good healthcare system, which, as you know, doesn't necessarily require IRB approval and is often local and is iterative and is fundamentally kind of atheoretical. It's really operationally based around sometimes plan, do, study, act cycles and targeting something that is really likely to be the change item to improve some sort of singular outcome. That is quality improvement operations. Now, quality improvement research is a bit different in the sense that, and there are kind of measures for that and journals now for that, which really, again, it is about targeting a specific outcome, like infection in an intensive care unit, and how might you do some sort of a process map to identify the particular stage where you're going to alter that and improve it. Implementation science really starts with the premise that we often have effective practices. And it may not be about improving what we do, but actually putting in place something entirely new. And if we continue to just improve the way we do what we do, we may not change things. You can think about, I think that BlackBerry, you probably don't even know what that is anymore. They tried to improve that over and over again, and that died. Polaroid tried to do the same thing with the cameras that they did, and Kodak with film. Sometimes implementing new things that are really game changers. And that's different than often quality improvement, if that makes sense.
Yeah, great. Thoughts on how to have an eye towards implementation while in the efficacy testing phase?
I'm sorry, what was the question?
Thoughts on how to have an eye towards implementation while you're still in the efficacy testing phase?
That's a really great question. So I guess when we think about efficacy, I think about several things in this area. One is this idea about designing for implementation. I've been increasingly convinced by my colleagues that, and by people who work in this area around user-centered design and design thinking, that sometimes the lesion, the downstream problem with implementation is not in the health system. It's not in the doctors. It's not in the nurses. It's in the fact that we didn't think carefully about whether the thing was scalable, generalizable, usable, and likely to really make it in the real world. So I think starting with the design thinking, user-centered design, think about scalability and also who you want to reach in the long run. Is it frail elderly? Is it ethnic and racial minorities? So designing for implementation at the get-go, even at the efficacy stage. And then I think when you're doing your efficacy studies, there's nothing to stop you from collecting some outcomes around how well was it implemented? You're still doing a controlled thing, but there's obviously places where you're going to learn that the thing that really made recruitment possible was not your brochure. It was this engaging person at the front desk, or the thing that made the thing blow up was the fact that there was some sort of step in the intervention that crashed and burned it for many people, and you just got to remove that. So observing carefully when you test effectiveness or efficacy can be very informative around downstream implementation.
Great. So when you when you're writing an implementation paper, what are the sort of the must-have elements in the method section that go beyond sort of A versus B trials?
Oh, yeah. Well, increasingly, and you can go to the major journals, implementation research, others, you can see the methods that are used, but certainly there's an insistence on what your theory is, what's the framework that you're using, and what are the kind of implementation outcomes that people recognize. So I think this issue, again, of theory, framework, outcomes, processes, context, those are pretty basic and fundamental. If it's atheoretical and you're just say, I tried to put in this versus that, I didn't really have a framework or a theory, it won't do well.
Great. Next question. How do you embed the consent process in some of the effectiveness studies to be sure they are true to the clinical process?
Wow, that's a great question. I have these conversations, as Christine knows, with our head of IRB about this area of science that we do, this area of pragmatic work within real populations. And I think that, increasingly, if we can't figure out a way to advance the informed consent process, the IRB process, to be truly inclusive, the types of studies we do are not really going to apply to the real world. And I don't know if this is answering your question, but I think about this all the time in implementation science, that sometimes we're consenting clinics and we're consenting CEOs. I've done that. And it's not about consent. And if we're randomizing clinics, we are collecting still patient level data at some not de-identified framework. Well, some IRBs have problems with that. If we had to consent, though, every single individual patient in our 48 organizations that we did this randomized trial in, the study would be over and it would not be representative. So I think it's really about educating our IRB. And here at Mass General Brigham, I have lots of conversations with our head of the IRB, and we even had a conference on equity-focused, research and how to really make sure that it's inclusive and representative. Really important question.
So I'm going to combine two questions with this next question. And that is really sort of how, as an early career investigator, might someone get started in implementation science? So one was essentially, how do you connect with effective interventions and appropriate research teams? And the other was essentially, do you think an early career scientist can do something like this?
It's a great question. I've thought a lot about this because I do think it's easier for people like Dr. Ritchie and me to talk to 48 organizations and recruit them than an early career investor, but it doesn't have to be at that level. I think a couple of answers to your question. One is joining or linking with interest groups or teams to learn about the field. That can be done. Increasingly, we have K Awards, early career investigator applications that are absolutely in implementation science as add-ons to an existing trial, maybe looking at barriers and facilitators, doing process mixed methods, doing kind of assessments of how the thing works in the real world. So one can add on to existing trials, work with teams that are doing this work, participate in interest groups, or increasingly there's workshops and certificate programs all over the place that can help to acquaint you if you're interested. You can also look at our website, if you want to cruise through that and learn a little bit. But I think it's possible for early career investigators to do smaller studies that are of great value, and then to partner on the large ones with more established investigators.
Very good. And in the spirit of time, I'm only going to ask one more question, and that is, how do you know when your intervention is ready for implementation? For example, if your palliative care intervention has not yet been demonstrated in your population of interest, should you do an implementation study or an effectiveness study?
Boy, that's a good question, and it's not 100% clear. I could say, if you were taking the hard line approach, you could say Implementation science is only about evidence-based practice. If you haven't had 2 randomized trials like the one I told you about, one initial trial, a replication trial, you can't do it. Well, that's not true. There are people doing these hybrid implementation trials where the degree of evidence is pretty good. You've got enough pilot data that it's highly likely to be effective. You could do a hybrid type 2 effectiveness implementation trial if the evidence is pretty good. However, one can always do, mostly, a type 1 hybrid where you're testing the effectiveness in observing the implementation, documenting the implementation, barriers and facilitators. I think almost we should not be doing, in my own opinion, effectiveness trials that aren't doing that. That seems to me to be not only a lost opportunity, but fundamentally a waste of money. I mean, just to test the thing in the real world and then not to see where it fell down, where it sailed, where it failed, it seems to me is not a good study, in my opinion. So I think one can certainly incorporate those into almost any study, in my opinion.
Well, thank you. And just to reiterate, Steve gave you some good resources. There are some really, really great web-based resources out there around implementation science. And I would strongly encourage you, if you're interested in this area, to go deeper there. Thanks so much, Steve. And I'll turn it over to Naomi to give us an announcement about next month's webinar.
Great, thank you so much. And thank you everyone for joining us. Next month, we'll hear from Dr. Maren Olsen about advanced statistical issues and how to work with a statistician. As always, you'll see a post-evaluation and we hope you complete that so we can improve our IDC offerings. And on that note, we'll see you next month. Thanks everyone and have a great day.